I'm going to invite our next session to make their way up to the stage. I'm going to be introducing our moderator, Dr. Terry Freed. This session is focused on communication, an expanding framework for understanding the role of communication in deprescribing. Before I introduce the group that's gathering up here, I'll just say that at the end of this session, we're going to briefly give instructions to help us organize one of the afternoon sessions right before lunch. So, so just to keep that in mind as this next session wraps up, we'll briefly explain an afternoon session to all of you before we have lunch. So it's my great pleasure to introduce our moderator, Dr. Terry Freed from the Yale School of Medicine. Dr. Freed is the section chief for geriatric medicine and the Humana Foundation professor of medicine at Yale. Much of Dr. Freed's research focuses on improving the quality of treatment for her vulnerable older patients by pushing for a more transparent networks communication work group. Dr. Freed.
Thanks so much. I realize we have the unenviable position of speaking to you right before lunch, but that's all the more reason to make this highly interactive so that you can't think about how hungry you are or what's coming up. We really hope that you're going to participate in a discussion. This is going to work a little bit differently in that the people who are joining me up here are all members of our working group. So I've been charged with presenting some of the work that we've done to create a communication framework. And then what we really want to do is we have 2 questions to start the discussion. We really want you to give us your feedback. And then our panelists are here to build on those thoughts and give some perspectives of their own for the framework that we've developed. So before I actually start presenting, I want to introduce the folks that are up here with me. So Sandra Koh, who participates as a caregiver and community advocate on our panel. She's a member of the U.S. Deprescribing Research Network's Stakeholder Council and is the primary caregiver for a parent with dementia. She serves the Korean American community in the greater Los Angeles County, particularly the older adult population, as both a member of the Korean American Health Coalition and volunteer at the Koreatown Senior and Community Center. I'm just going to take this opportunity to give a shout out to USDEN about their involvement in stakeholders in all the parts of the research that they do, because Sandra has brought to our working group ideas that those of us who spend our days in the academic community would not have thought about and would not have put on this framework. So we're very, very appreciative of her participation. Nancy Schoenborn is sitting next to her. She is Associate Professor of Medicine in the Division of Geriatrics and Gerontology at Johns Hopkins. As a practicing geriatrician and researcher, she's conducted extensive scholarship on incorporating patient preferences and overall health trajectories in individualized decision-making and communication with older adults. Dr. Schoenborn is also a U.S. Deprescribing Research Network pilot awardee. And I will say that as we were studying communication, we realized that Nancy was actually one of the few researchers who actually was looking at how we use communication in a very practical way to do de-intensification of care. Next to Nancy, we have Richard Street. He's a professor of communication at Texas A&M University. His research focuses on understanding and improving clinician-patient communication and pathways linking communication to improved health outcomes. Dr. Street co-leads with myself and with Marcia Mecca, who is in the room there as well, the Deprescribing work group. And I've had the good fortune of working with Rick for a long time now, and Rick does this amazing job of bridging the conceptual and the practical in a way that makes sure that the group really thinks carefully about the components of communication. And last but certainly not least, we have Bob Waller at the end. He's Clinical Associate Professor in the Department of Pharmacy Practice at the University at Buffalo. He and Dr. Rajit Singh, who is also in the room and on our work group, co-lead Team Alice, an initiative at the University of Buffalo which has done extensive work advancing research, education, and practice change around deprescribing. Dr. Waller and Dr. Singh were the first awardees of a grant planning award from USDEN and parlayed this into a recently awarded R18 grant to improve deprescribing communication for older adults using community-based methods. So with that, let me, this time is just gonna go too fast. Let me jump in and talk about our other communications work group members. I believe that several others are in the room. Ariel Green, I know, is here with us. But you can see that we decided the communication was not specific to the US, so we invited some of our international colleagues to join us. And I have to just say quickly about this group that it is the most amazing group that I have ever worked with. People putting up with, I don't know, for those of you who've ever tried to schedule a meeting between Australia and the Northeast of the US, people putting up with 7:30 in the morning meetings on the one hand and 6 o'clock in the afternoon meetings on the other. And people have been so incredibly generous with their time and energy and thought that this really couldn't have happened, I don't think, with just any other group of people, and I'm very grateful. So, what was the motivation for this work? Well, so when, and this is actually, I like that this talk comes where it is because I think you're going to hear echoes of a lot of things that you've already heard this morning, but we're gonna attempt to put a structure around it. So much of what we've been hearing about is, in terms of communication and deprescribing, is what you see on the left. This idea that you have a clinician who's explaining to a patient why he or she shouldn't be taking one of the medicines anymore that they are on. But we quickly realized that that was actually a very, very small component of what we have to think about when we think about communication in deprescribing. Communication is like the great unknown. If you think about it, communication permeates every piece of deprescribing, right? You need the communication about figuring out which drugs are the drugs that are going to be targeted. Who's communicating about that? To whom is the decision maker? And then how is that being communicated to the patient and or caregiver who's going to be making a decision about taking or not taking the medicine? So we decided we were going to try to put our arms around this larger notion of how does communication fit into deprescribing, and specifically into deprescribing interventions. So what we did was that we used a consensus panel method for developing this framework where we debated, discussed different drafts to really get people's input in an iterative process about what this would look like. We did this simultaneously with a literature review of what's actually currently going on. And the literature review kind of helped us think about, okay, well, what's in the literature that we haven't included in our framework yet? But then, I think, and most importantly, we used the framework to go back and evaluate the evidence, to be able to say what's been done, what hasn't been done, where are the opportunities to look at communication and deprescribing. So we did 2 critical reviews to examine the literature. For those of you who are less familiar with a critical review as opposed to other reviews, we weren't attempting to figure out actually what these studies, deprescribing studies, were showing. We actually really wanted to look at the conceptual component of these studies. That's what a critical review does. So in the first review, we looked at deprescribing randomized controlled trials and pulled out in a structured way the communications components that have been utilized in these trials. And then in a second review, we evaluated studies examining communication and its association with knowledge, attitudes, and skills, and I'll show you why in just a moment, as I put up on the board our current working framework. So let me walk you through this just a little bit, and then we're going to spend more time on it at the end. So in the center, I do not have a, doesn't look like I have a, oh, wait, do I have a? arrow? Maybe, maybe not. Yeah, there we go. Yay. Okay. So, in the very center of this diagram, we put shared decision making. We debated a lot about what should be in the center of this. Why did we decide on shared decision making? Because we tend not to think about this often enough. But the only way that deprescribing is going to happen is if there's a clinician who thinks the medicine should be deprescribed and the patient agrees that the medicine should be deprescribed. That's really how you get there, is a process of shared decision making. People have to both understand the benefits and harms, agree about what those are, and agree about how that fits into what matters to the patient. So you can't have deprescribing unless you achieve shared decision making. I'll give you a preview. Is that included in any of our trials? No. So for those of you who are thinking about writing your next grant, there's an idea for you. So in this central, as I talked about, what we tend to think about is this innermost circle of a clinician who's interacting with a patient and or a caregiver in a particular clinical setting, primary care, a nursing home visit, a house calls visit. And if we're very lucky, we have a pharmacist who might actually be working in that inner sphere as well. And so what we know is that there's going to be some communication among all of those parties, and there's communication content, what we're talking about, and communication style, the way that we go about talking. But that's just the first of several rings. And so the next ring is really the health system, which will include subspecialists, nurses, other care providers, pharmacists, who are feeding information potentially into that inner circle. We heard about academic detailing, for example, earlier. That's actually just communication where somebody in the health system goes in to talk to the clinician to try to educate the clinician about what benefits and harms of medications are. So you can see that we have various forms in these gold arrows about what goes on from that outer circle into the inner circle, academic detailing being one, patient-specific feedback is another. That's what a lot of the computerized systems do, is collect information about the patient and feed it back either to the clinician or to the patient, or both, about, hey, this is potentially a problematic medication. You might want to think about deprescribing it. There's also audit and feedback, and you can have general education. Those are all examples. It's not meant to be exhaustive, but meant to give you examples of the way that this health system sphere interacts with the innermost sphere. But then importantly, we started to hear a lot about this in the last talk. We can't forget about the community or the public realm in which this all occurs. So what happens out here? Well, that's pharma talking directly to patients via direct-to-patient advertising. That's patients getting on the internet and seeing what the internet has to say. That's patients talking in their faith-based or community groups to see what the ethos is about medications and prescribing. And that's also where consensus guidelines live. That is another way of identifying inappropriate medications. And so some of the ways that the community realm influences what happens in the innermost realm is through direct-to-consumer advertising and other things like that, lectures, anything that happens in the community sphere. This all sits on the base of the social determinants of health, as we definitely heard about in that last talk, that the social determinants of health can influence communication in all sorts of ways that we've barely scratched the surface of. And some of this, we think, is mediated by the attitudes, values, knowledge, and skills that patients, caregivers, and clinicians bring into that encounter. So there's kind of this interaction that communication shapes attitudes, values, and skills, but those things in turn shape communication. So this is our picture, and we're going to come back to that. Before we do that, though, what I want to do is show you what did we learn when we use this to evaluate the evidence about what we all are doing currently in the deprescribing realm. In the effort of time, I'm actually going to skip over some of the more descriptive stuff. And let's go straight to what we learned about who's included in these studies. We divided this up. We saw that there were basically 3 baskets of interventions, those done in outpatient or home care, those done in the inpatient setting, and those done in nursing home assisted living. We were curious to know about health status criteria for inclusion in the studies. You can see what kind of health status was selected for in these studies, mostly in outpatient home care or inpatient. I think because the presumption is that in the nursing home, most of the patients that we're seeing are going to be carrying a load of geriatric conditions. The social determinants of health, we tried to capture this by looking to see, okay, so how often was this even considered in terms of who's being included or excluded in the study? Are we focusing on issues related to race, ethnicity, income, rurality? So interestingly, what we found was that social determinants of health are only used right now as an exclusion criteria. So we're excluding the people for whom it's harder to communicate with, either because they don't speak the language of the dominant country, they don't have permanent housing. Most studies don't refer to this at all, but important to note that there are no studies that are focusing on these as issues that are important to communication. In terms of knowing what the medications are that are being targeted in these studies, there's also, we didn't include this in our diagram, and we may have to think about how to, but it's important to think about the fact that we have different targets for deprescribing. So we have either studies that go after the entire medication regimen as a large review versus those that are targeting a specific class or a few specific classes or individual medications. And you can see that the majority of the studies are actually looking at the entire regimen. So this is another really important thing. So now let's narrow down on this communication. So we asked who's the source of information that there's a problem with the medication. And what you can see is that overwhelmingly, the source of the problem is coming from that external or consensus criteria. What I want to draw your attention to, and then the next most, which is reassuring, is that the pharmacist is taking a look. It is very, very rarely the patient or the caregiver who's the source of information about whether there's a problem with the medication. The next thing I want to tell you about is, okay, so then who is the recipient of the communication? And these numbers don't add up to 100% because many studies have multiple recipients of communication. And you can see that the clinician is the recipient of communication in a vast majority of studies, the patient and or the caregiver in fewer. Now, you're going to say to me, how can that be if, again, the idea is that the physician is talking to, or another clinician is talking to the patient about stopping a medication? We didn't extract it if there was no attempt to standardize what that conversation looked like. So what this is telling us is that there's really very little attempt to try to figure out how we help that individual clinician and patient talk to one another. I very quickly want to talk about the fact that there is a lot of heterogeneity in terms of what kinds of ways that we are having this communication, with print material being the most common, and there's, you can see the rest of how that shakes out. And that's when the method of communication is to the clinician. When we look at the content of that communication, what we see is that most of the content is recommendation for deprescribing or education about the risks and benefits of individual medications. Okay, what's missing here? Nothing about how do you communicate with your patient about how to do this, as we saw, and also very little feedback to the physician about what the patient thinks or what the caregiver thinks about what's going on. When it's the patient and or the caregiver, again, usually we're targeting those people with print materials. Less commonly is there some sort of direct encounter in which there's communication going on. And if we look at the content of that communication, it's suggestions or recommendations to stop taking a medication. Only 8% of the outpatient studies attempt to coach the patient on how to talk with their physician about stopping a medication. So again, and even fewer talking about how this fits into the patient's goals. So when we heard about personalizing this interventions in our keynote address, very little of this going on. So let me just summarize then what we see about this literature vis-a-vis our diagram here, which is that virtually all the studies are implicit about what goes on here. There's very little attempt to actually structure what that looks like or examine what that looks like. There's virtually no attention to social determinants of health, and we didn't find a study. So I think somebody in the earlier talk referred to understanding how, for example, community or faith-based groups could affect attitudes toward participating in a study. But why can't that be part of the study? We didn't see any evidence of an attempt to bring that into the work that we're doing in deprescribing. Let me look at the time. I'm actually going to very quickly then talk about what we know about what goes on in this innermost sphere and how it affects attitudes, values, and knowledge and skills. Very, very little. While there's lots of studies about general attitudes toward deprescribing, when we went to look at the observational studies that actually looked at willingness for a patient to deprescribe a medication or for a clinician to recommend deprescribing, we found a total of 12 studies in total. 7 of those were qualitative. 2 of those actually analyzed clinical encounters. There was one mixed method study that also analyzed clinical encounters. None of the studies attempted to link how communication actually influences those knowledge, attitudes, and values, or vice versa. So very little mechanism of how we actually use communication as a tool. So what I'd like to do now is to actually open this up to the group by, with a few discussion points that I'd like for us to consider. So first is this idea that public health approaches to deprescribing are really not being explored. And I'm very curious about how people feel about that and if they see a role for that in their own work. It's worth noting that the Canadian Deprescribing Network is ahead of us on this. They actually have so there's a shout out to our Canadian colleagues. They have a public engagement strategy. And I did not see that in any of our materials yet, so something to think about. The prevailing model of deprescribing interventions is really a narrow one, where most of the studies start with external criteria, feed that to the physician, who then has some sort of implicit communication with the patient. When you contrast that again, whoops, I was hoping to go backwards, but maybe that I can't do that. That's a very small portion of what is on this slide. And then the last discussion point is, again, the ideas that there's virtually no consideration of the roles of social determinants of health and little basic study of communication. So the way we wanted to open this up was for 2 questions that we can see if people in the audience have thoughts about, and if not, we'll have our panel members start the discussion, which is, I really am curious about this use of this outer ring and how we might bring that into the work we do, because that really feels like a lost opportunity. And then as you review the conceptual model, and I want you to think about this in the context of your own work, what feedback do you have for us? What have we gotten right? What have we gotten wrong? Is this helpful as a framework? Could you imagine using this in your next grant? If so, how might we make the picture easier for you to use? Anything that you might have to tell us. So I'm going to leave with the picture up for us to be looking at and invite if the audience has any thoughts about those points.
Hi, Jinjia Wang. I'm from Rochester. I'm a neuroscientist. I see some familiar faces from my past encounters. Great talk. This is definitely a very important topic. I have a quote to share from a patient that I included in my study, and a question. So the quote is, my sphere is all about home health care. So there's chronically homebound patients. There's also post-acute care patients who are transitioning from the hospital or inpatient post-acute care settings that are going home and home health care go in and help them review their medication. We open their medication cabinet and are surprised by what we see. Or patients tell us things and then we kind of think about how to help them. I recently completed a very small pilot study where we tested the feasibility and acceptability of implementing some of the deprescribing components in home health care. One of those components is patient education and communication. I want to share this one quote with you. The patient, particularly this patient, is from a lower SEM background, who doesn't really have as much of an access to seeing all the providers that she would love to see. She said the communication piece empowered her. Empowered is her word. Empowered her in the way that she didn't know how to talk to her provider about deprescribing. She didn't know that she has the right to ask if I want this medication off, or if I'm suspecting I'm probably suffering side effects. She didn't know how to bring it up to her provider. That's the quote I want to share. The second I wanted to kind of share is a question. I do see that social determinants of health is a very important issue here. And in my study, we kind of explored how we potentially can instill assessment of SDOH in deprescribing work. And I found there's two things that you could do. And I'm kind of curious about your thoughts about other things. One thing is transportation. So if the patient has no way of picking up medications, one particular one, or if the patient has a hard time affording it. Those are the only two things that seem to kind of be very relevant. I'm curious, about what your thoughts are, how to organically structure or use the social determinants of health to inform deprescribing beyond transportation and cost issues. So great stuff. Thank you.
I'll let the panel go ahead and tackle whichever of those questions. I think the empowerment one is perhaps the one we should start with in terms of what our experiences are with thoughts about that and how we've attempted to represent that.
Yeah, I can try a little bit. We've really, in the literature, did not find a lot of that, and I know one of the things that I wanted to comment is there are probably programs similar, Canada being one of them, where things are active yet not published. So we did not, we're not able to extract them. I know within our group, we've created empowering videos based on a story of a woman who died in our community after being exposed to cyclobenzaprine. That's our Team Alice. We've just worked on a senior center curriculum, so similar to what Delon was talking about before, bringing it to a community basis. But I think there's just a lack of what's been published on that as well.
There you go.
Okay, thank you. And along with that, I'm echoing all the points that I heard earlier as a community member and caregiver. I think even before having a deprescribing conversation, just in the point of empowering, like, can I take up that space? Do I have the right to ask that question? Or can I, is that even like an area I could go? And then really, who are the people who are planting those thoughts in my head? So it's even, it's just like different components, like an idea entering someone's heart. Can I ask that question? And then an idea entering one's mind, like, does that make sense? and who's telling me, who's the trusted source, who's telling me the stories. Is that my daughter? Is that my pastor's wife? Or, is that the lady in the hallway? But, of course, the doctors. And also very dependent, empowering means very dependent on the culture. So for my Korean older adults, if I took a picture of here and said, like, look, all the smart people who went to amazing universities and working in the field are talking about this, they're like, ooh, that they will think that, like, that's empowering to me. Now I'm going to ask them questions about that to my doctor. Like, okay, it's a good question to ask. So I think, like, even the notion of empowering is not just, like, me knowing the right, but it's, like, who is telling me the story, who's, saying that's the right question to ask. So a lot of cultural component and then language barrier. And then also, like, the worries and fears that come with it, right? Like, if I make that choice, because I was empowered and I asked that question and I am about to engage to that decision because, like, I was nudged by different people who were credible. But once I do that, once I make the decision, what's the aftercare service? Like, I made the decision, I made the change, but then later I'm gonna make a phone call. Am I gonna get through the line even with the interpreter, or am I gonna have to bug my daughter again for the 9th time? But I also bugged her for, like, oh, can you call because the water is not working? But this is gonna be another call. Can I get through the line? So all those components of language barrier, cultural barriers, who's telling me the story, all that comes back to define what's empowering. So I think that's a good study to be, held, and that I invite, folks to, like, maybe spend, like, a week in a senior center near you, or, like, in a church and faith-based, and see how the decision making is done among the members. It's just fascinating to watch. Sometimes, like, oh, mom, look at all the stories, and, like, the adults in the senior center, like, all the stats and story, and then, like, they will ignore all of it, but I'm like, so-and-so in my hallway said that's a good idea. So I invite you to be in the community and just really have that experience, yeah.
Yeah, and I think just to echo before is the idea again of the importance. It brings out again this idea that we might be ignoring the most influential components of what somebody's bringing to the table when they're having a communication, if we don't think about the total sphere. Before we take Anand's question, I don't know if Rick or Helen, did you have anything to add?
I would only add that we've talked a lot so far about things to get clinicians to overcome their inertia and talking about deprescribing and things like that. And interventions that we've thought of ways that much more effective are often getting patients more activated, because the problem there is that they aren't sure what to do, as you were talking about, what to say, what's their role and things like that. But when you mention that in the example here about being empowered, when I can do that and that kind of thing, because what happens in the shared decision-making part is you've got to bring it up in the conversation. If it doesn't come up in the conversation, nothing's going to happen for the most part. So there are opportunities for patients to bring that up, and of course those kinds of interventions need to be done with care in a way that's culturally appropriate, validating, and all of that.
And I think this is a great opportunity to really learn from people who work in the community or work in the media, and kind of bridge our research expertise to scopes that may feel unfamiliar. So thinking about people in advertising and people who put public messaging campaigns and what the direct advertisements from pharma looks like, right? There's a lot of science in designing the images and the context that look pleasing and attractive and persuasive, and there's a whole body of science. And I think there's an opportunity to really tap into that and study, well, how can we publicize deprescribing, that to change the culture, like maybe this is something everyone should think about, and that taking less medicine should be like a goal, right, in the community at large, right? So to shift that culture. So I think there's great opportunities there to learn from other disciplines and bring that innovation into designing our study interventions.
Hanan?
So you know what I'm going to harp on here. So so in your shared decision-making bubble, I understand that there's a proportion of any of those 4 individuals who are going to have deprescribing or something about the medication as the decision to be made. But I think in most cases, the decision to be made is identifying what the outcome goal is, what do we want to try to achieve, and then de-initiating, de-intensifying, all the things that Dr. Chowdhury talked about are action plans to help to get to that goal, and the shared decision is around the outcome goal.
Thoughts from?
Well, I guess the only thing that I would say about that is when you think about the outcomes in mind, those aren't always necessarily the ones you go into the clinical encounter with. Because during the course of the conversation, there could be a number of changes in that regard, depending on how that conversation unfolds. But as it unfolds and decisions and a treatment plan are being made, then that is where they need to take the form of these things that are action plans that make it very clear on what the steps are to be taken, when to follow up and to check on it and things like that. So, I mean, the emergence of these things that happen during the conversation, I think, are something that's really important to be mindful of.
And I think Anand's comment just highlights that there's any number of ways of engaging patients and clinicians in the process of doing shared decision making. And you can start with the decision, you can start with the outcome. I think the important take-home message from what we saw is that our deprescribing studies aren't doing either of those, so that there's a large space again for figuring out what really is the most effective approach in order to engage, right, what happens in that innermost sphere.
Yeah, a starting place is that the doctor and patient realize that there is a decision to be made. Otherwise, nothing happens. But I guess my question is that there is a risk communication literature that I'm really interested in how this applies to deprescribing. So you need accurate information. The doctor has to communicate that to the patient, and the patient has to have enough literacy and numeracy to understand it. And then communication works the other way, where the patient has to communicate their preference to the doctor. So, and there are lots of ways of communicating risk information. There are pictures and numbers and fuel gauges and pictographs and Kaplan-Meier curves, and you know, they each have pros and cons, and sometimes are better aimed at the patient versus the doctor. And decision aids also sometimes have a values clarification exercise that the patient fills out and then hands it to their provider and says, here, let's have a conversation. So so I'm really interested in the point that you made, where there are very limited studies about how do different methods of communicating risk to the patient, how might that affect the outcome? So is that kind of what you had in mind, comparing different visuals or numerical presentations, and then how does it also work the other way from patient to clinician?
Well, so I'll sort of tackle that first, just to say that it is true that thank you, we didn't plant you, but to say that the next year of the working group is actually going to focus on this inner circle. That was where we started our talks, but we decided that we couldn't really do that until we understood the larger context in which this was occurring. So with that being said, we're going to focus on that communication between patient and caregiver. You could argue that your question is even one question too specific, because there's actually a debate about whether people use specific information or whether they use GIST. There's a ton of additional things that we're going to have to think about in terms of what's going to be helpful in terms of studying what goes on. I think we share, and if I'm wrong about speaking for us, less of an interest in doing that work where there are other people working in that area, and more actually what we've been doing more recently is trying to come up with actually the taxonomy of the different kind of deprescribing scenarios to see if we could maybe map different styles of communication and communication content onto those different different typologies of the decision. So that's the direction we are thinking about going.
Yeah, if I can just follow up with a comment, I think about, and Rick probably can comment more on this, there's communication about the specific decision. That's where I think about, like, a good example of a decision aid is very balanced. It has, incorporated these in detail, the specific benefits and harms. And then, but if you think about what pharma ads show, they don't have any of that, right? That's really changing kind of the attitude and bringing deprescribing to the awareness of the public. Like, hey, this is a thing that you can actually get off medicines, that the medicine you're on don't have to be stayed on forever, right? That maybe fewer medicines are better. So I think there's that kind of a specific communication in that inner circle in a particular encounter perhaps, but then I think there's also a broader communication that may not need to be as detailed to kind of bring about that awareness is, I think, part of our thinking as well.
And then to follow that, there's also the unspoken communication, right? So I was thinking, like, what am I doing here today? And then it is because there's Dr. Catherine, that anytime I'm in the emergency room or like dad suddenly stopped eating in the nursing home, then I could call her and ask questions, and I have assurance that, okay, like this things, steps will help me guide to the next. But many of the older adults, like low-income adults that we work with, they don't have the helpline or call to make. So the minute I leave this 5-minute appointment with the one doctor who speaks this language, then I don't know if I have that line to call. So if there is a communication, it's not a written literature or the way you speak it, but there's a unspoken communication that you can give them assurance that if I make this change or if I go through this process, that there will be a way that I could, still get the guidance further, that I won't be left alone. And I realized a lot of challenges that I saw in the community cultural barriers, that it's same as the challenges in the rural area. So I think although it's different challenges, there are a lot of similarities. But so I'll bring it back to the unspoken communication as well.
I think this will have to be our last question. Yes? Ariel?
Sorry, I'm feeling very short right now. Well, of course, there's definitely so much need to skim a lot of potentially inappropriate and harmful medicines off of the surface. I think there's also, when you get down to it, like these shared decision-making conversations are about trade-offs, and so I'm curious about what are the right outcomes if the focus is shared decision-making? Like, what are the outcomes we can measure that are convincing about deprescribing, like to health systems, for example, if sometimes in these conversations, even though there's so much need for, improving access to non-pharmacological treatments like we heard earlier and educating people about the harms of medicines, but when you get down to it, sometimes the gabapentin is helpful to the patient and caregiver, or the antipsychotic is helpful. So I'm just curious about thinking about outcomes.
Thoughts? It's a big question.
Yeah, Ariel, you made me just kind of think about data that I saw, and I can't quote it directly. What do seniors most worry about? And one of their greatest fears is losing their cognition. Another one is being placed in a facility. So those might be the types of outcomes that we would want to identify as a target for communication, that these medications might cause you to be confused earlier in life. We would like to get those off. These could cause you to fall. Some of those outcomes to me would be maybe the tangible ones to focus on with empowering a patient.
Well, I think we're at the end of time. I appreciate the questions. I think I would just encourage, as you continue to think about, because I think that what we've failed to do is to have communication be an explicit part of our approach to intervention. So as you're continuing to think about that, Please, if you have feedback for us, because this is a work in progress, let us know. If you have thoughts about what would be helpful to you to have us work on in our next set of meetings as the working group, let us know. We really want to have more of a communication with all of you about this. So thanks very much.